Hi everyone, I've given my AMC Clinical face-to-face examination on April 2025. Here in this video, I'd like to share my experience with the exam, particularly the surprises and learnings on the exam day. Now, this is not a video discussing the exam questions as such. As you might already know, most of the questions are from past recalls, and enrolling in any reputable bridge course will give you access to all of those. What I do want to focus in here is those unexpected moments. During my preparation, I've given 4 full-length mock exams and practice role plays with multiple study partners. While all of that were incredibly helpful in honing my approach, certain things caught me off guard during the D-Day. Just a general disclaimer, AMC Clinical is a subjective exam. Hence, the experience can vary across different exam days and sometimes even among candidates within the same session. Before diving into the main content, I'll quickly walk you through the logistical details of the exam day. First, about the check-in process. You'll be checking into the exam floor after showing your IDs. Please make sure to review all the ID requirements from the AMC website itself. Afterwards, you're allowed to carry your stethoscope, medicines and snacks like protein bar or chocolate into the waiting room. Rest of the luggage can be kept in the locker facility provided. In the waiting room, water, beverages and biscuits will be provided. You're free to use the washroom facilities here. You'll be spending at least 1 hour in the waiting area. There are couches and single chairs in there, so if you want to socialize and keep yourself entertained, choose the couches. Or if you want to sit by yourself and meditate, choose the chairs. When the exam starts, a marshal will guide you into the exam hall. You may only take your stethoscope inside. If you have meds or snacks with you, hand them over to the marshals. They'll keep it safe for your rest stations. Now regarding the stations, you'll get 2 minutes reading time, following which you will open the station door and get inside. Examiner will check your ID. For PE stations, the examiner will instruct you to wear the gloves. There will be multiple boxes of it and all of it are free size. So don't worry about your glove size. And the gloves are those thick purple floppy ones, so your percussion notes may not be clearly distinct. Now for the non-PE stations, examiner will instruct you to use the hand sanitizer. It's that super bubbly one. The more you try to rub it off, the more bubbly it gets. So just take a very small pump, roughly rub it and move on with your performance. Now the examiner will introduce the patient to you. This is your patient. His name is Mr. X or Mr. John. And it's a good idea to jot down that name on the piece of paper provided because patient's name won't be mentioned in the stem. A hard copy of the question will be provided in front of you and it will be also displayed on the screen. So you don't need to worry about memorizing the task. It's a good idea to quickly glance the screen just before moving on to the next task. An alarm will sound once the time for your first task has elapsed. Now regarding the rest stations, there will be water provided for you. You're free to use the restrooms now. You can also collect your snacks or medicines from the marshals if you had given to them earlier. Now getting on the topic proper, as we all know, each station is of 10 minutes, 2 minutes reading time and 8 minutes performance. And those 2 minutes are absolutely crucial. During my preparation, I followed a consistent strategy regarding the reading time. First glance at the task, then read the stem, then go back to the task in detail, plan a strong set of differential, and if time permits, maybe plan the opening statement also. But on the exam day, this could work only for less than half the cases. Why? Because while practicing, I was used to one-liners or short blocks. But in actual exam, most of the stems were super long with multiple paragraphs that filled the entire screen. 2 minutes felt barely enough to just finish reading that. That being said, this wasn't necessarily a bad thing. When they give you such a long stem, the diagnosis is usually clear before you even walk into the room. That was about the long loaded stems. There indeed were few one-liners as well. And there came another surprise, the importance of the role player's opening statement. I had a station with a one-liner stem about a middle-aged woman with sleep disturbance. I thought my reading time strategy could finally work here, and I drafted a set of differentials, primarily psych differentials like generalized anxiety disorder, depression, PTSD, or med differentials like hyperthyroidism, caffeine use, obstructive sleep apnea. But the moment I walked in, even before I introduced myself, the role player said, "I feel so hot at night, I just can't sleep." Now, this is a case of hot flashes, not a true insomnia. And the actual diagnosis turned out to be perimenopause. So the takeaway here is to listen carefully and be flexible in your approach. It's not just about the opening statement, but pay attention to the gestures too. I had another short stem about a 37-year-old multiparous woman who came for antenatal checkup. No symptoms or complaints mentioned in the stem. As soon as I entered, the patient started telling, "Oh, doctor, I just want this pregnancy to end fast." And while doing that, she was rubbing her chest. Now, that was indeed a clear nonverbal hint. That case turned out to be GERD in pregnancy. So don't just listen, observe. As a continuation to what I said about long stems, I had 3 full-on counseling stations, and all the 3 had particularly long stem with detailed information about patient's background, social history, and personal context. Although it might feel a bit overwhelming at first, these are not just fillers. It's given so that we can tailor our counseling approach and not just blurt out a memorized management plan. So use the context to keep your patient involved in the counseling process, reflect their concerns, and adapt your approach accordingly. The next surprise was about the tasks. While preparing, I've been following a preset template: history, physical examination, diagnosis with full differential set, and management. We were told to prepare 8 to 10 differentials as a must, almost like a survival kit to pass the exam. However, on my exam day, AMC was much more creative with the task design. Out of my 16 stations, only 3 asked for differentials. In contrast, 4 stations explicitly asked for risk factors, and many more focused on explaining the diagnosis and addressing the patient concerns. Now coming to the PE stations. I had a case of a woman who sustained chest injury. I had been practicing PE on male subjects, so I didn't really anticipate the added layer of sensitivity when performing the same examination on a female role player. Now, we all know about the need of chaperones in cases of genital and breast examination, and not addressing that can be a critical error. But here's what hit me on the spot. Even checking the apex beat in an RS case or a CVS case can be sensitive. And I only realized that after I had already started the examination. My next PE involved a female with acute abdominal pain. During inspection, asking her to expose the abdomen also felt retrospectively uncomfortable. And here's the other side. If you have only practiced on female subjects, tasks like knee examination could feel physically different. The key takeaway here is to practice PE on both male and female subjects. The next one is something I was prepared for, but didn't really understand the depth of it until the exam day. In your PE station, as you're putting on the gloves, take a moment to look at the table. They don't explicitly tell you this, but you're expected to use all the objects kept there. For example, I had a patient who sustained a leg injury while gardening. A lot more details were provided in that long stem, like he's diabetic, patient is not able to walk, the swelling is increasing day by day, etc. I did the classic look, feel, move routine, but after I was done, I noticed cotton wool and toothpicks on the table. Now that was a silent nudge to check for peripheral neuropathy, and the final diagnosis was cellulitis with diabetic neuropathy. In my acute abdomen case, there was a torch on the table, and that was for checking the hydration status. Now, one thing I had always worried about during the practice was, will I sound genuinely empathetic on the exam day? Because let's be honest, we all know these are role players and not real patients. But here's what surprised me. The role players in the AMC exam are incredibly talented. They bring in real emotions, real anxiety, and subtle expressions that make you feel that you're actually in a hospital setup. And because they are so good at what they are doing, your own empathy flows more naturally. Adding on to that, during the mock test, the role players would usually give brief, structured answers, mostly yes or no. Because of course they are medical doctors and not trained actors. But during the actual exam, the role players made it feel much more realistic. They engaged in actual conversations, asked follow-up questions, reacted emotionally, and sometimes even steered the dialogue. So here's the big takeaway. While practicing with your study partner, don't keep it dry. Be dramatic. Act distressed, shocked, withdrawn, or even irritated. It makes you more exam ready and also makes your practice sessions more fun. During the preparation, we are repeatedly reminded about the importance of chaperones, confidentiality, and empathy. However, after my own exam, I realized that we don't give enough credit to a sensitive psychosocial history. On my exam day, 2 stations were explicitly psychiatric in nature, where psychosocial exploration is naturally the core of consultation. But my non-psych cases included tension headache, psychogenic cough, perimenopause, and non-accidental injury. And in all of these, a crisp psychosocial history was absolutely essential. In short, addressing the psychosocial factors was needed for half of my mark stations. Now, the next point is something I learned the hard way: the strategic use of the piece of paper provided to you. During my preparation, I trained myself to only write down the patient's name just so that I don't break the eye contact. I had a case of trigeminal neuralgia. My tasks were to ask history and counsel regarding the management. During history, I picked up that the patient is having habits of alcoholism, and I knew that I had to address it during counseling. But here's the catch. As soon as I mentioned carbamazepine, the patient jumped straight to asking about side effects. From there, we went down to the risk-benefit analysis, alternatives, and all of that. I still had time left afterwards, but I completely forgot to bring up alcoholism. Needless to say, I failed that station. And the lesson learned? That paper is your safety net. Write one or two code words for the must-address points. So no matter how much the conversation drifts, you can glance down and close the loop before time ends. Now, another big learning: don't judge your performance based on the examiner's or role player's reaction. In one of my stations, the examiner was nodding happily to everything I was saying. I walked out feeling confident, only to fail that station with a global score of 2 out of 7. On the flip side, during my tension headache and non-accidental injury stations, I genuinely thought I irritated the patients during the history taking. Yet I was awarded 7 out of 7 and 6 out of 7 respectively. Adding to that, in stations with a psychosocial component, role players might be actually instructed to act irritated. So don't waste your energy trying to read the room. Focus only on covering the tasks. Another thing I learned was not to guess which stations are pilot during the exam. I had a case of chlamydiasis, which is a heavily repeated station. But when the results came, it turned out to be a pilot. Then the very last case I had appeared unfamiliar to me, but it was actually a marked station. So treat every station as if it is marked, no matter how familiar or unfamiliar it feels. On my exam day, thankfully time was not an issue. In fact, I actually had some spare time left in most of my non-PE stations. Now, you're allowed to step out early once you're done, but it takes a lot of courage to do that. What I usually do was to wrap up by asking, is there anything else you want me to address or anything else you want me to know? And most of the time, the reply will be a cold, is there anything else you want me to tell? But in one of my counseling stations for mild depression, when I asked this closing question, the role player suddenly said, can you suggest me something to help me sleep better? And addressing sleep disturbance is actually one important aspect in depression management. Without asking, I might have missed that altogether. The next point might sound a bit silly. Don't assume the patient's BMI based on the role player's appearance. In my sleep disturbance case, it was important to rule out obstructive sleep apnea. The role player looked overweight, but in history, she denied any weight gain, and on the PE card, her BMI was 23. In my GERD case, one of the tasks was to address the risk factors. Now here the role player looked very much in normal weight range. However, the PE card mentioned her pre-pregnancy BMI as 31, which is a significant risk factor for GERD. I had a case of lymphedema counseling wherein the role player was a middle-aged woman with a normal build. But the photos shown clearly showed a patient with high BMI, and the weight management is definitely a key issue to address here. That's about my exam day surprises and learnings. Next came the 3-week wait period for the results, a period with hyperanalysis that robbed the peace of my mind. I was certain I had failed 2 stations, confident that I would surely pass maybe 3 stations, and rest of it totally on the fence. Finally, the result day arrived. I opened my AMC account, only to know that I failed the exam, that too with a dreaded score of 8 by 14. After the initial grieving phase, the logical next step was to prepare for the next date. But here was the catch. The earliest exam date I could target was in October, and by then all the RMO campaigns will be closed. Being an overseas candidate, getting a job out of campaign may not be impossible, but highly improbable. Hence, I was sure I won't be giving the exam again anytime soon or anytime at all. However, with around 1-year time period and significant financial investment made for both parts together, completely giving up was hard to accept. That's when I began exploring the option of an appeal. I started asking the past candidates on WhatsApp and Telegram about their experience with the appeal process, only to learn that hardly anybody ever had any success with it. Also, for some candidates, it took 8 to 9 months for the results. So I mailed AMC directly and they clarified that the process usually takes 2 to 3 months and that each appeal station is reviewed by an appeal panel of examiners. First, there is an administrative check followed by the assessment from one examiner. If that examiner marks the station as a fail, it remains a fail. If they mark it as pass, the station is then reviewed by a second examiner. Only if both examiners independently agree, it will be declared as pass. Now that I have decided to go for an appeal anyway, the next question is which stations to include. As everyone says, AMC clinical marking can be unpredictable. Stations I felt unsure about often scored well, while those I was confident in were marked down. Nobody really knows what are the checkpoints the examiners have on their iPads. Past candidates have advised appealing stations where the predominant assessment area score is high, or the stations with strong individual assessment score areas despite a fail in the global score. I had a case of vaginal candidiasis. The tasks were to take history, explain the diagnosis, and discuss risk factors. I identified an undiagnosed diabetes in the patient and was confident in my performance. I genuinely believed that if I had to pass only one station in this exam, it would be this one. Yet I failed in both global score and predominant assessment area. For my own closure, I have decided to appeal the station. Then I had one case with the infamous 4-4-4-4 yet global score fail. That was my trigeminal neuralgia case, wherein I forgot to address the alcoholism. Right after the exam itself, I knew that I wouldn't be passing the station. However, given the pass score in all the individual assessment areas, I decided to try my luck regarding this. Since I'm already appealing a station I expected to fail, I thought I might as well include 2 more cases that could go either way. About 10 weeks after lodging my appeal, the results arrived. The vaginal candidiasis station was overturned to a pass, while other 3 remained as fails. Thankfully, that was enough to alter my overall result. And that concludes my experience with the AMC Clinical Examination and the appeal process. I hope this account helps others who may be going through a similar situation. Thank you.